Here's case 4 for the EMT course, building on our previous cases 1, 2, and 3 with one more, mostly trauma-related case. Prereq things that you should already know are definitions of tension pneumo, and then think about it from a blunt trauma aspect as well as an open wound. In this case, you won't have an open wound, and what will you do then? And if you think back, this was one of the transfer of learnings that we did for case 3, was what if you encountered this very thing that you're encountering in case 4. So what is a flail? What is a pulmonary contusion? And what do you do about a trauma code? More prereqs. What in the world is a Glasgow Coma scale? How do you deal with a head injury in combination with other multiple systems trauma? So you've got a guy that's got head injury, head trauma, in addition to chest, belly, pelvis, femurs, some other sort of trauma. How do we provide positive pressure ventilation to a breathing patient? We tend to think of it as, well, your patient's not breathing, so you breathe for him. But what if your patient is breathing but ineffectively? How do you breathe for him in that case? We really want to coach through some of that in our lab setting. And then what are the negative side effects of positive pressure ventilation? We are negative pressure breathing animals. We aren't meant to have positive pressure. So when we do something unnatural to our patients, there's going to be side effects, and what are those? Here's the terms, which you should already know, the top 2 lines worth from your previous cases. We're going to add flail chest, pulmonary contusion, and we're going to add this whole GCS thing in here. So here's some terms you should know. As far as the call goes, it's a little different this time. Your role is BLS ambulance. You can transport. You don't have to wait for paramedics to arrive in an ambulance to transport. Now, you won't have any medic support, but you can at least start moving. You're going to have an 8-minute response time to the call, and then you have to decide, am I going to go east, 12 minutes to the full-service ER, or I'm going to go west, 12 minutes to the trauma center? So they are not in the same direction. You can't head for one and then just go on by and go to the trauma center. It's in different directions. So we're adding a little complexity here in terms of your destination decision. Dispatch info, it's a Delta response, predicted high acuity, motor vehicle crash with high mechanism is the verbiage they use. It's I-70 at the 116, which is J&O, so that's west of Columbia, for those of you not from around here. And so, yes, I know the hospital location is fictitious, but we needed it for the learning thing. So when you're at the 116 mile marker, you're going to have a choice of one direction or the other, in one direction for the trauma center and the other direction for the non-trauma center, basically. Lights and siren are clearly indicated. You're coming out of our station 9 on Midway, and you respond. The further information is a rollover, single vehicle, single patient, ejected. So now you start your pre-plan, and you think, oh my, ejected is never good. So your mechanism of injury could include internal and external bleeding, and you may or may not have a head injury. Likely that there's hypovolemic shock, possibly there's obstructive shock, probably a critical trauma patient. This is probably going to be a trauma center transport. It's pretty hard for a guy to roll his car, be thrown out of the car, and not have significant enough mechanism that it produces some injuries that then makes it reasonable for him to have trauma center activation. So here's what it looks like. The car's off the road, looks terrible, very broken. There's several bystanders. The good news is the patient is out of the car, so there's no extrication. That's bad for the patient, but good for you. And there's several bystanders attending to the patient. When we coach this in the lab setting, we want to talk about managing bystanders. They're not always worthless. They're not always a great deal of help. And so you need to kind of assess them and use them when you need another set of hands, but make some judgments about their viability as a helper. So you walk up to him, and the bystanders say he got thrown out of the car. We didn't drag him out. He was thrown out. He's not talking, but he is breathing. You say, hey, what's your name? He doesn't respond. You put some pain to his nail bed. He grunts and groans. He does not open his eyes. He doesn't move his extremities. He has no radial, but his carotid is rapid and weak. Skin's cool, pale, and moist, so you know he's in hypovolemic shock right now. Ventilations are fast and labored and shallow, and you wonder if maybe he's got something going on in his chest. He's got no cyanosis yet. Remember, you have to have enough blood volume left to really even generate cyanosis, so it could be that he's got significant internal bleeding. Your urgent action is to start ventilating him. He has poor oxygenation, poor circulation, but he needs to be ventilated. Find some chest injuries if they're there. Find and place any occlusive seals that would be necessary. Consider that there's got to be underlying lung damage. There's external bleeding to be controlled, but you really need to get moving. You need to really get moving. And so if you've got some additional first responders there, you may want to snag some more help. If it's just you and your partner in a BLS truck, partner's got to drive and you got to go. Treat him for hypovolemic shock as much as you can and monitor for any developing tension pneumo, but you really wouldn't be able to do anything with it, would you? I mean, if it's a blunt chest, there's no open wound for you to unseal, so you're kind of stuck, which means it's even more imperative that you get him to a trauma center for care by the trauma team. And then even if you have a head injury that is suspected, it's the same initial treatment for this guy. The head injury may be what ends up killing him, but we're not going to manage it any differently. And any head injury patient has a much worse outcome if they have any one episode of hypoxia or hypotension. So you really want to try to prevent those as best you can. So he's a critical trauma. We're not going to get any actual vitals right on the scene. We're just going to use estimates. He doesn't have a radial pulse, so we know he's hypotensive. He's rapid, shallow, labored on his breathing, so he needs at least a non-rebreather and probably positive pressure. If there's just two of you, you're really in a world of hurt. You may need to put him in the ambulance and get him squared away and just provide some ventilation as you can. And then once you're in there, get some help from your first responders and so you can actually do ventilation. So he's got diminished bilateral lung sounds. I don't know if that's a pneumo or a hemo-pneumo or big bad bilateral contusions. Who knows? But what I do know is it needs to be ventilated. So what do we know about history and stuff? Well, it's a single vehicle rollover. We don't know. Did he just fall asleep? Was he drunk or high? Did he have some kind of medical thing? Maybe he had a seizure or his blood sugar's really low. Who knows? Maybe there was a deer that ran across. Maybe somebody ran him off the road. Who knows? It doesn't really matter right now because he's so sick that whatever happened has already happened, and you need to prevent further bad things from happening. Can we get any history on this guy? Well, unless there's something on him, like his phone or medical alert tags or scars or stuff in his pockets, really not much we can get. So we don't want you to blow past this. But we also don't want you to spend a bunch of time trying to find things that really aren't there. So look for some clues during your exam. He's nonverbal. We'll talk about his GCS, 221. So his eyes are a 2, his motor is a 2, or his verbal is a 2, and his motor is a 1, which gives him a 5, which is really bad. Most medics think that if you're not at 8, they need to intubate. So you should take that bit of information and say this guy is well below the threshold where if you were a paramedic you would be intubating him. So he's going to need some airway control. He's got a great big bad hairy bruise over his left chest. There's no obvious flail. Remember that flails don't always show up right off the bat. The intercostal muscles will spasm and support the unstable injury for a while. And then the flail will show up later when those muscles fatigue. His lung sounds are clear but diminished, harder to hear when you're on the road. Be sure that you get lung sounds before you start transporting because it's much harder to hear them in a moving ambulance. His trache's midline, for whatever that's worth. He doesn't have any JVD. Remember, it takes blood volume to create venous distension. So if he is bleeding out internally and has lost a fair amount of blood volume, he's not going to have enough blood even to distend his jugular veins. So we're working on assessing tension pneumo here based on hypotension and loss of lung sounds, more so than this trachea and JVD stuff. His abdomen is soft and non-tender, no other injuries noted. That's fine because he has a bad enough chest injury to cause him big problems. What's your plan? Well, we're going to keep watching him while we're going as fast as we can. We're going to get vitals as best we can. And as you see, things start to deteriorate, and then they go really bad. And he eventually, a couple minutes later, is a trauma arrest. What do we do for trauma arrest? We go fast. Well, we were already going fast, but we go fast. If we had an open chest wound that was sealed, we would release it and just leave it open. We're going to start compressions, attach the AED, do all your usual stuff. There's nothing wrong with an early supraglottic or extraglottic device. So a King or a iGel or whatever you've got would be great. And then consider those causes, even though you can't manage any of them. Here's your inbound report. And this is before he coded. If he was in trauma arrest, your inbound report would be 10 minutes out, 20-year-old male ejected from a motor vehicle crash in full arrest. And that would be it. Here's your handoff. And we're considering that the handoff happened after he coded. Self-debrief. This can be a very dramatic call. Definitely going to be on the news. Definitely going to be in your head for a while because you had a patient who wasn't dead that then got dead while you were taking care of him. And so you're going to wonder if you did something wrong, if there was something else you could have done. And so you need to go over this several times in the self-debrief as well as your video debrief. Make sure you know about tensions and all that stuff. Here's the written report. Here's your video debrief again, and then questions. When and why did you know he was in shock? What type or types of shock? Why was his GCS so low? Well, it isn't because of the shock, folks. He had a head injury as well. Were you going to do anything with that? Not really. The things that you were going to do were things that you were trying to do. And so that's, it is what it is. Why did he go into cardiac arrest? Well, I don't think it was anything you did. But you're still going to always ask yourself that question. And then why were the lung sounds diminished before you arrested? Transfer learning, was there a visible flail chest? What if there was? How would you treat that flail any differently? Go over that. And coaches will need to talk to you about that because we know that the way to manage a flail chest is positive pressure ventilation. We know that a flail chest comes from broken ribs. Broken ribs cause pneumothorax. A simple pneumo can turn into a tension pneumo by positive pressure ventilation. So we have two competing situations here. Your interest or need to stabilize that flail may actually turn this into a tension pneumo for which you can't do anything. So critical thinking, judgment calls are all over the place in this call. Why was his LOC so low? Same as what GCS so low, it's a head, in addition to other things. What do you think went on in the ER with this patient? That may also be a good clue for you. If they do something in the first couple of minutes in the ER that you could have done in the field, maybe you should have done it in the field. And then if you were the first arriving firefighter, how would you manage this call? So those of you in the public that are public students in the EMT course can learn from some of the things that our firefighters and fire recruits will know. By the time we get to this case, the fire recruits will already have covered this in their program, and our regular members will certainly be able to show you and talk to you and help you learn about how they would manage this call from a total scene perspective. So there has to be patient care, but there also needs to be some scene management and check for hazards and that kind of stuff. So that's a good opportunity for both our public and our fire people in the EMT program to interact and exchange some information. So that's the end of this case.